Yeah, good evening and good morning to people in US. This is the first webinar we are having on controversies in vascular surgery. Super specialty course is a yearly program done by the Neurological Society of India for neurosurgeons who are less than 45 years of age. But this time it is open for all, everybody. And because we cannot, normally we do it for 1.5 days in a center where the faculty and the delegates spend time together. But this year, because we cannot have it for 1.5 days, we have divided into 4 webinars of 2 hours each. It will be on second Wednesday of this month, September, October, November, and December. And in Indian time, it will be 7 o'clock from 7 to 9 p.m. So all the 4 things will be have discussing on controversies in vascular surgery, and this webinar is more dedicated to controversies in treating aneurysms. I'd like to thank all the faculty from US and here. This is being done with the invited faculty from CNS, and each time we have one CNS speaker as well as one CNS panelist. And there will be equal number of CNS and Indian speakers and panelists. I'd like to thank Professor Mishra, Dr. Clemens, Dr. Sanjay, Dr. Paritos, Dr. Lokender, and Dr. Babu, and Dr. Suresh for spending the evening to make the events useful and fruitful for everybody. Now, is the topic relevant? Why did we select controversies in vascular surgery? I'll take 2-3 examples of cases which our speakers will finally give us ideas how to manage them. Like this case, last week, Dr. Vikrant from Gujarat had sent for an opinion. This patient came with an SH with a blister aneurysm. Now, what is the best way to treat? Because there has been the endovascular surgeon says that flow diverter is better, but then the surgeon feels that the patient cannot afford it. So whether a bypass with trapping is an alternative option, which Dr. Paritos will be speaking on, not only on blister but other indications of endovascular treatment in ruptured aneurysms. Now, what do you do for this case, which we saw 2 weeks ago, a paraklenoid aneurysm, wide? We suggested both surgery and endovascular. Patient preferred endovascular, but unfortunately, they could not place a pipeline. They could not place a flow diverter. In The interventionist could not do it. So, what went wrong in our decision making? Dr. Sanjay Bihari will be explaining how to prevent this kind of failures in our treatment planning. Now, this case we had seen 6 months ago. Now, this patient had a large aneurysm, the ICA bifurcation, and the NCA and the ACA were coming from the fundus. Now, both the intervention radiologists, they said it's difficult to treat, and we also felt it is difficult to treat. And so what is the best treatment for this kind of cases? If you look at the statistics, this paper which came in JNS in 2019, when the pipeline flow diverter came in 2010, the number of bypass came down from 140 to 64. But then over a period of time, it has increased. This shows that pipeline is, though it was thought as panacea, it is not true. There are a lot of indications where surgery has a role. Though many papers compare surgery versus endovascular, whereas this paper compared stent-assisted coiling and flow diversion, or a deconstructive and reconstructive. When we see this, that the occlusion rate in both is almost 70%, whether it's a ruptured or an unruptured aneurysm. Whereas the recanalization rate is almost 40 to 47%, which many endovascular surgeons may not agree, but that is what they have published. The chances of retreatment is 32% and 48% in ruptured, and this is ruptured and this is unruptured. So these are, and the chances of early aneurysm rupture is 5 and 8%. So looking at that, whether we are treating logically, do we have evidence that endovascular is a better option than surgery? Now, if you look, the only class 1 evidence we have for clipping is for clipping and coiling. But then parenteral occlusion with bypass or flow diversion All of them are class 4 evidence. So what is the best way to treat? What is the future? Is it a combination of endovascular treatment with bypass, or only endovascular is the future? That's what our speakers, Professor Mishra, Professor Clemens, Professor Sanjay Bihari, and Dr. Paritas will tell us. It will be followed by opinion from the panelists, Dr. Lokendra Singh, Professor Lokendra Singh, Professor Babu, and Professor Suresh Ankla, followed by question and answer. With these few words, I'd like to request Professor Lokendra Singh to introduce and invite Professor Mishra.
Thank you, Manas, for this wonderful and very lucid introduction of the topic. Actually, you have made this very relevant, this whole discussion now. And before I invite Professor Basant Mishra, I must, as a president of NSI, I must thank Dr. Babu and Dr. Clemens, who are the representative from the CNS, to join us for this academic fees. And we'll be very happy to listen them and know their views about it. Now, Dr. Basant Mishra, Professor Basant Mishra is a very well-known figure. I think I need not to introduce him. He's very well known all over the world. He's the first vice president of WFNS, and he's running now, we all know, for the office of president of WFNS. He has our best wishes. He's the honorary president of AASNS also, and he's head of department of neurosurgery, as well as he's in charge of the gamma knife radiosurgery unit at Hinduja Hospital in Mumbai. He will talk about microsurgery or endovascular treatment for intracranial aneurysms. Is there still a debate? So let's see what points he puts forward for this. Please.
Thank you, Lokendra. Thank you, Dr. Singh. Thank you, Manas, for inviting me to this very nice webinar. It's always a pleasure to be part of these education programs. And I must, kind of congratulate you for getting this, started with the CNS collaboration. We have a long history starting from 2008, actually, when we started. I don't know whether Babu or Clemens know about it, but the first interaction between NSI and CNS was in way back in 2008, when we had about we had interaction when Dave Edelson was the president of CNS, and we did interact with him. And 2009, NSI, almost 100 neurosurgeons attended your CNS meeting in 2009. And 2010, about 50 plus CNS neurosurgeons came to Jaipur, and that was the beginning of our collaboration and cooperation. And thank you very much, Manas, and the CNS leaders for keeping this up. So let me share my screen. I think Manas gave a very nice introduction, and I'm sure there will be overlap because people will be talking about the same things. So let me give you some of my thoughts. So this is the landmark paper in Lancet in 2002. And of course, and as we say, rest is history. There was significant impact on practice, and many patients were treated by endovascular means, and some many rightly so. But what we sometimes forget over a period of time is the evidence. What was actually the evidence? So let's go through some of the evidence which is available, and that can be through the randomized studies or the meta-analysis. And the points to ponder is the feasibility, the durability of the treatment, the risk of rebleeding, and other complications. Why do we need to treat an aneurysm? Basically to protect and a complete occlusion to prevent rebleeding. Just putting in some coils or flow diverters or whatever, stents inside doesn't help if you are not completely occluding the aneurysm. So let's go through some of the evidence. So the randomized studies, to my mind, what are available, of course, the first one was the ISAT, and then we have had the Finnish study, the Lee study from China, and the BRAT, which has been published. So this is the first one which changed the paradigm in the management of intracranial aneurysm. This is the initial report for 1 year follow-up. Endpoint was MRS more than 2, and coiling obviously did much better. there was a significant difference in the outcome, and the coiling being superior to the clipping. Was there equipoise? They talked about equipoise, but if you go through the detailed data, the 12 deaths in the clipping group were prior to treatment in clipping cohort, because there was delay in the treatment. And all these were included in the clipping category, and that's why the data was so much skewed. The other thing which is very important for the young neurosurgeons to go through the full data and study and understand that the very small percentage of the patients who were screened could be randomized, because of the fact that those only patients, less than 1/5 of those patients could only be randomized, because those were the patients were equipoised. So 80% of the patients were not randomized because the investigator felt that these are not actually equipoised. So that over a period of time, many of us have forgotten that there was a small percentage in those select group of patients, usually the common garden sacular aneurysm in good grade in anterior circulation, and in those, the first year, 1 year follow-up, the outcome was better. What happened subsequently? The 5-year follow-up, the endpoint, the investigators changed the endpoint, not MRS more than 2, it became 0 and 2, but there was still no significant difference between the outcome in the clipping and the coiling category. 10-year follow-up data in the ISAT, again, there was no difference in the survivors. But again, the investigators changed the endpoint from MRS to the endpoint was now death, and that favored coiling. But again, if you go through the data, many of the deaths were not from the aneurysm, but for other causes like cancer and so on. So we are not treating aneurysm to prevent cancer. So one has to be very clear. One has to go to the details of the data before you understand what actually we are talking about. And what happened to the rebleed rate was higher in the coiling group, and the retreatment, of course, was significantly higher in the coiling group. And this is in ISAT, based on which all the treatments and the paradigm changed. The 2000, the Finnish study, a very large group of patients they have, and they published, there was no difference between microsurgery and the vascular treatment. The Li from China published in 2012, again, there was no difference between the outcome between the two groups. Now that's the last one, the BRAT, that is Spetzel group from Phoenix. And they published 1 year, 3 year, 5 year, and now 10-year data was published in JNS in 2019. And the last analysis, if I go through that, you will see that there was all the patients, there was no selection. Every patient who had subarachnoid hemorrhage were included, and they were very good, matched. And if you see carefully what happened in this, the crossover. 36, 1/3 of the patients who were put on the endovascular arm could not be coiled and moved over to the clip group. So there is a significant number of patients who could not, one of the best centers in the world of vascular neurosurgery, could not be treated by endovascular means and crossed over. And go on to see the complete obliteration at 10 years, abysmally low in the coiling group of 22% only, and the clip was 93%, and the retreatment again was much higher significantly in the coiling group. So the main goal of our aneurysm is, number one, complete occlusion and prevent bleeding. And they had 2 patients who bled in the coil group and none of them who bled in the clipping group. So again, this data, which was initially first-year data, there was some significance in some of the groups, never became significant in the subsequent data. And in fact, was the clipping group of patients did much better, both for complete occlusion and retreatment risks and bleeding risks. What about meta-analysis? This is published in 2019. 11 studies with 3 randomized control studies of 4,517 patients, a large number of patients. And they found from the literature there is an increased relative risk in endovascular treatment for recurrence, for retreatment, and for rebleeding. So in the data which is available in the literature, as of today, it is very clear as far as complete occlusion rate, it is significantly better in the microsurgery group. the rebleeding rate is higher in the endovascular group, and so also the recurrence rate is higher in the. So one has to remember that. Of course, there is a group of patients who are probably better treated by endovascular means. So also there is a group of patients who are better treated by microsurgery. And the data is worse, like Manas just pointed it out. And if you go for giant intracranial aneurysms, the occlusion rate is much less. The risks are much higher. And there are risks of, in fact, one of the studies which in 2016 published when they did the MRI, 62% of patients had MRI evidence of ischemia. So all is not hunky and dory, and the panacea which we thought that the pipeline sent or the flow diverter will change everything really didn't happen. So let me go through some of the examples, some of the patients, how they can be better treated by microsurgery with hemorrhage, with ischemia, and with mass effect. So this is one example of a lady who presented to us in coma with a large subarachnoid hemorrhage, intracerebral hematoma, bilateral Nsi aneurysms. The right one had bled. You see, this is the circulating, there is a thrombus component. All the vessels are coming out of this. There is a Nsi aneurysm, which is M1 actually, and branches coming out. And none of the, to my mind, even today with all advances, it would be appropriately completely occluded by the endovascular means, and especially with this kind of aneurysm. So we treated it. It can be done, and that's what we did. And this lady took a long time to come out. She remains hemiparetic on the left side, but otherwise functional. The other side, we called her back after 3 months of the recovery and then did the other side. So both sides complete occluded, remains occluded. This has been about 7-8 years now, and with no further problem. Of course, compromised because of her bleed that time. The aneurysm like this young man with the completely blowed out ICA, which presented with subdural hematoma in another center in coma, decompressive craniectomy, and sent to us for definitive management. And of course, over a period of time, he came to us, and by the time he came to us, he was asymptomatic. So he sat over it till we operated. Again, this type of aneurysm, the whole extent, I don't know how many flow diverter, whatever you need to do. So this, we excised this aneurysm and did a bypass. And he also had an incidental basilar top PCA coming out of this. We sent it to our endovascular colleagues, which failed because the PCA could not be saved. So in 2 different sittings, what we did, first time we excised this aneurysm, decompressed, and did a high flow radial artery bypass graft. And when the endovascular treatment failed, and we did a basilar top aneurysm clipping microsurgery. I will skip all those videos, and this is before the discharge after the 2nd stage surgery. Both aneurysms have been taken care of. And this is another example where endovascular treatment failed. This gentleman who had a post-traumatic repeated epistaxis, blind on the right eye, came with this pseudoaneurysm bulging into the sphenoid sinus. We sent it to a very, kind of a very established and senior endovascular colleague in Mumbai. And because the patient was already sick, so we thought that would be the first option. And he sent us back because there was a fracture segment lying inside the wall of the aneurysm. And he said, if you put a flow diverter, this artery will just give way. So then we did a bypass, again, high flow bypass graft, radial artery, and trapped the aneurysm. In a point for aneurysm, the pseudoaneurysm, just ligating the neck is not enough. So one has to also do a trapping because otherwise there can be reverse retrograde bleeding. Again, another example where it's difficult for endovascular treatment is aneurysm associated with Moyamoya disease, presented with subarachnoid hemorrhage. And this, we did a STMC bypass along with the clipping of this aneurysm. With the same sitting, we did both. Again, better treated by microsurgery to my mind. Now, patients who are presenting with ischemia. Now, this is a lady in 70s who presented to a neurologist with an infarct. And it's a very distal MCA aneurysm with a clot inside. This is the very distal. She's 70 plus. She had the left side MCA infarct. Now, if you see, we occlude the feeding arteries, but we have left one artery so that some circulation continues. And then we open this aneurysm. You will see there is a clot inside. And we remove the clot, and we suture the artery, what we call inside to revascularization. And then there was bleeding, and then with that vessel which we had left open, that back bleed, and then we occlude it, and then teno suture, we suture it, and so the vessel becomes patent. Of course, he had a hemiparesis, it took time, but he otherwise recovered very well. Now, this is a man in his 60s who presented again as an infarct to our neurology colleague, very small circulating component, but a very large thrombus component. You see, this is one of the microscopic view. And again, none of these endovascular means can take care of this. We decompressed, endarterectomy, the MCA bifurcation, and opened up the aneurysm and clipped it. Now, patients were presenting with mass effect, and this is one of my, very, very interesting patient I've seen shown in many meetings. The child, 2.5-year-old child, who actually presented. I'll come to that later. Now, this is a gentleman who is in the 50s, who presented the progressive visual compromise. Now, when he came to us, his vision was still okay, but the right side was bad. And all his vessels were diseased, the right side, the left side, and the posterior circulation. And we really didn't know what the best way to take care of it. But he, over a period of 1 year, he kept on losing his vision, and he almost forced us to do something. So we went on and did, again, the very simple treatment of radial artery bypass graft and ligated the carotid in the neck to buy some time. He's going to have problem because all his vessels are diseased. But I think we gave him some time for stabilization of vision, which actually remained stabilized for some time because of there is no flow there. Now, this is a young fellow in his teens who presented with intractable headache and visual compromise, who failed endovascular treatment, was sent to us by our endovascular colleagues for microsurgical treatment. Now, it's a distal ICA aneurysm, very, very thick walled, unruptured, with a mass effect with visual compromise, and no clip would sit there. So we are holding the aneurysm, trying to make a neck by the bayonet forceps, and then we put multiple fenestrated clips with blades being parallel, like typical with the parent artery, and then we're trying to preserve all the anterocorridor and the perforators, and so proximal to the distal, and then from this side. And then with the ICG, this is MCA, ACA, but there's still some circulation which we could not take care of because there was a compromise where we are at risk of the perforators. So we accepted that. And this is what we landed off with. This is what we started off with. And this is what was left, which was sent back to our endovascular colleague. He had a mild, you can see there's a little bit of weakness on the left side, which improved over a period of time. And this was, of course, much easier for them to treat. Now, what about the proximal ICA aneurysm, which is now almost standard of care of endovascular treatment, flow diverters been the standard of care. Now, I'll tell you, this is not the true story because many of these patients' complications we do not see in the literature. I have, in a period of 1 year, seen 3 such patients. And this is the examples I'll give you. This is a ophthalmic aneurysm, unruptured, was treated with flow diverters. He had minimal visual compromise over a period of time. He completely lost on the left side and severely compromised vision on the right side. Nothing could be done. See significant edema of the optic tract, chiasma, and so on. Never been reported. Now, this is a ACOM aneurysm, flow diverter and coil. Again, 3 months down the line, visual compromise, bitemporal hemianopia with significant edema there. Again, never been reported. Now, this is a more recent case in another, again, very, very eminent center, treated with a cavernous carotid aneurysm, very appropriate for endovascular flow diverters. First patient presented with ophthalmoparesis and right side visual compromise, flow diverter put. Over a period of months, he started losing his vision, became completely blind on the right eye. So, and the repeat investigation, so the aneurysm was still feeling, so they put a second flow diverter, second treatment setting, flow diverter, stent, coils, and so on. And then over 3-4 months, he became completely blind on the right eye and starting vision, losing vision on the left eye. You see the mass effect there, and the aneurysm is still filling. So as I said, this is not the end of the study. Unfortunately, many of these cases are never reported. And so we don't really know. There has never been a study. There has never been a randomized study comparing flow diverter with or without. So we don't know the real story to my mind. So if you have a large aneurysm like this, like a 4 centimeter aneurysm, this is a lady who presented a visual compromise, is better treated by microsurgery to my mind rather than endovascular. This is what we did, a temporary or a protective STMC bypass before aneurysm or RAFI, multiple clips. There was some redundancy, but which we accepted, so the patent artery is intact. And this is the child I was talking about earlier, a very famous case of mine, 2.5-year-old child presented with hydrocephalus, altered sensorium, heavily thrombus, calcified, basilar top aneurysm going very high up. You can see that there. And we did a shunt, the child became asymptomatic. So this is about, I think, 9 years back. And this patient, our endovascular colleague put 17 coils that time. Aneurysm was very well occluded. But over a period of 2 days, the patient very rapidly deteriorated to become decerebrating. Shunt was functioning, CT scan showed hydrocephalus was decompressed. So we had no choice but to go in. Again, I'll skip the video. But we did the OC craniectomy, extradural anterior cranectomy, intradural posterior cranectomy, dorsomus drill, thrombectomy, and then we clipped the aneurysm. I'll skip that video. I think he had a very stormy, obviously, post-op course in the ICU, 6 weeks, tracheostomy. But at 5 years, now it's a 9-year follow-up. Now we have. See, just last month, the father is a pharmacist who sent me his data to me just recently. He is going to school, he's all right, but this is the 5-year follow-up, only some ocular motility problem, no lower cranial nerve deficit, going to school, completely functional, and this is 5-year follow-up MRI showing the brainstem is intact. A few months after that child, we got this adult patient with this aneurysm, similar aneurysm, a little smaller, again thrombus, basilar top, and this time we of course did not send the patient to our endovascular colleague, surprisingly easy aneurysm. We did the same thing, OC, extradural anterior cranectomy, intradural posterior cranectomy, drilling there. And this few millimeter makes a huge difference to go to the neck without compromising, without significant retraction. That's the aneurysm, that's the PCA. The neck was completely free of thrombus. The thrombus all in the fundus. So we didn't have to open this one. We did put 2 multi-curved Yasser-Gill clips and they occluded the aneurysm. That's the PCA. That's a ICG, PCA, branch of PCA, right side, contralateral PCA. And this is the immediate post-op CT angio. And all this complex aneurysm, we have a post-op DSA because CT angio may not be completely informative. And this is the patient, he had a mild temporary ophthalmoparesis, mainly third nerve, but 3 months down the line in my clinic for follow-up, no deficit, no ocular motility problem, and completely occluded aneurysm, which remains occluded till date. Now, this is the last case. Again, something which I think is extremely difficult to by any endovascular means. All the vessels are, this is again a child with a vessel top aneurysm presented, compromised with subarachnoid hemorrhage, a circulating component, a CT angio is not giving all the information, which will show that probably the neck, there is a neck which we can do something. But when you did the 3D DSA, you see all the 4 vessels coming out from the aneurysm, including the perforators. So this is what we did. And this is the last hypothermic cardiac arrest, which I did. We don't do it anymore. And this has been many years now, 5-7 years now. And this is probably, again, something where we can do it. The child remained compromised. He improved to only, responding to his parents, taking about heavily compromised and not ambulatory till now. But child, I hope that gives some. So my conclusion slide, I think it's important that we individualize, do what is best for the patient and not what we love to do, whether it is endovascular or microsurgery. After all, it is his brain. I think to answer the question, is there still a debate? I think jury is still out. Thank you very much for your attention.
Yeah, thank you, Professor Mishra. And we'll have the questions and panel discussion in the last. I request Dr. Babu to introduce Dr. Clemens and invite to the lecture. Dr. Babu, you have to unmute yourself.
Great. So thanks for having us again, and it's great to be involved. We like the morning lectures, so I hope we don't have a problem staying awake. So I want to introduce Clemens Shermer, colleague, friend, and co-officer. We've been involved with the cerebrovascular section for a while. Clemens has recently been elected as the chair-elect, so he'll follow. I was the chair this year, Adnan Siddiqui, and then Clemens will follow. So a nice lineage for us to kind of keep making moves in cerebrovascular neurosurgery here in the U.S. Clemens is at the Geisinger Hospital, which he's showing you there, and he's the vice chair and program director of the Department of Neurosurgery and the Neuroscience Institute there. In the U.S., we have a CAST Endovascular Fellowship. It was a pretty significant movement where our neurology, radiology, and surgery are all together in terms of certifying credentials for endovascular treatment. So that CAST movement is slowly growing, and Clemens is involved, has been involved with that at his hospital as we have here. He's also, I think his role in the CNS has gotten this involved in terms of the executive board member and international division chair. So as we have spoken about, I'm really happy that we're having these international interactions, and I hope we can make them a little bit more in person as the years go on. We all have things to give, and I hope Clemens' talk on innovation and open cerebrovascular procedures really has that international feel that we want. So Clemens.
Yeah, thanks, Babu. And again, to our friends in India, thanks for having us. This has been, a great collaboration over the last couple of years, as Professor Misra was mentioning this, and we're looking forward to making this even stronger and going forward with this. It's a tough act to follow, what we just heard. So I'm actually glad that I'm able to focus on just like a very particular niche here. Some of the problems that we have in the US are a little bit different. We don't have, necessarily as many gigantic, huge problem aneurysms as were just shown in one talk, I guess. Here sometimes the choice between endovascular and open surgery is also driven in not a small part by the patient and their perception of open cerebrovascular surgery and how bad that can be and how long you spend in the hospital and what is involved basically. So we took a little bit of a look at this and tried to essentially make this better. To give you a tiny bit of an idea of where I am, because you may not have heard of Geisinger, this is an integrated health system, meaning that we have our own insurance company on one side, we have a medical school on the other side. We do have multiple hospitals. We have 3 comprehensive stroke centers here. And we cover a very large portion of Pennsylvania. And we're a decently busy shop. We do about, 4,000 procedures or so per year. And we took a look at our craniotomies in particular, and vascular craniotomies for aneurysms, the elective ones in particular. And we're discovering that there's a couple of principles that you can apply to them that actually leads to predictably better outcomes. And this is following a methodology and set of ideas that in Europe has been popularized under ERAS, early recovery after surgery. Mostly, this is something that the colorectal surgeons are using, and they've been using this with quite some success. And they can show that, these are some studies that talk about this, showing that, using this methodology leads to predictably better reduction in complications, shorter length of stay, better outcomes through that. And we took some of these principles and really took a hard look at, but how can we use this in craniotomies, I guess? And it has the promise of multiple wins that you can get out of this. And we built a module or a program around this, starting with the decision points for surgery. That includes whether or not a patient like this may be eligible for an ultra early discharge. So we're talking about basically craniotomy that is done on the same day as the discharge. So you don't actually stay overnight. It does have elements of education. It does have elements of nutritional supplements. It's very important. Because we do believe that surgery in itself is an inflammatory stimulus to the body, and preparing the body with the right nutrition before and after is important. Making sure that you screen the right patients, for smoking cessation, ambulation, how far can they walk? Is there things that you can optimize with that patient before their surgery? And then, of course, the perioperative management. And this is something where we also reached out across the aisle. We worked with anesthesia a lot and really changed, how many opioids, for example, these patients get intraoperatively and then postoperatively. And then how do you, look at this postoperatively and circle back and close that circle? And we built in some metrics here that are allowing us to prospectively evaluate how well this program is working, basically. This is quite complicated. This is not something that I'm just doing. This is basically a system-wide standard of care that we've embarked on. I'm going to talk a little bit about the vascular aspect of this and how this affected my practice. But there's multiple people involved. We give very detailed instructions to our patients and make sure that they have the right expectations. Again, setting the right expectations in my mind is super important. It is something that is frequently not done very well. If you, just to make an example, if you tell that patient you're going to be in the hospital for 5 days, this is complicated surgery, we expect that to be a 5-day stay. And then let's say everything goes great and you on day 2 come to that bedside and say, look, it's been great, you can go home today. They're going to look at you as like, but you told me it's going to be 5 days, right? So setting those expectations, even though we think we can be flexible about these things, the patients oftentimes take this as gospel and don't want to necessarily err off that. We use checklists to make sure that people are following the best practice elements that we basically prescribe through these programs. And it is really a series of highly choreographed steps. And this also includes the intraoperative component of this. And this is something where, again, I think we need to look at, as surgeons, at our own, noses a little bit, because we love to stereotype and standardize, everything that happens outside of the operating room. But once we cross that threshold inside of the operating room, right, we're the captain of that ship. Nobody should tell us what to do. And I think that's something where, working together and learning about those best practices, what other people do to achieve success, that is really an insight that, we had at our institution, and, that has led to some interesting successes. So one aspect of this is looking at the exposure. We also, we always have the standard terional approach, right? But often in a lot of aneurysms, do you actually need this? So looking at your particular pathology and asking yourself, what is the absolute required exposure that is needed here, and how small can I make this, will have some ramifications, obviously, going forward. And I'm not necessarily telling you anything that you don't know here, but putting this together as a sequence of steps that you have to go through as a surgeon for every case and justify what you do is really important. So, and I intentionally don't want to show you just the fun part where I potentially clip the aneurysm. I just want to give an idea of how big or small exposures are. This is probably actually one of the medium-sized exposure. It's the right supraorbital approach, and it's pretty straightforward, right? So there's nothing fancy about this. I'm sure all of you listening are capable and very much able to do this approach. I'm just gonna click through this here a little bit. The point here is that I try to really hide the burr holes, and I'll get to this later, underneath the areas of the skin that are covered by muscle, and not have this open to the outside or the scalp, because what happens is that you oftentimes have retraction of the scalp into those openings. And you can really, I guess, also tailor your craniotomy based on the boundaries of what is, other structures that you need to respect and that you can get away with. I put, little slots into my craniotomies. I actually don't use a perforator, again, to avoid the problem of having to cover that afterwards. And that is because this is how this looks, making little slots that are just enough exposure to get your your foot plate in there to open those. You know, I really try and like keep these things covered because that leads to less potential problems with wound healing. You know, the harbinger of an infection is of course always there when you do a craniotomy. You know, using lots and lots of irrigation, and then also using the minimum amount of hardware that you can to put this bone flap back is really, really important. This is what happens when you don't pay attention to this, especially when you're in an area where you see your patients back for decades, which is what we have here. Our patients don't move very much, and there's no options for them to go to another competitor across the street. This is what you get if someone does just like a really nice burr hole, and then years later, the skin has sunken in, and this is a major problem here. So paying attention to these little things is important because I can also tell you, even though you may have saved this patient's life, 5 years, 10 years down the road, all that they care about is that hole in their forehead. And they're going to come to you every year and say like, yeah, what about that hole, right? Whether or not this was a complicated surgery on the inside, they actually don't really appreciate this very much oftentimes. And even though they're thankful to you for their care, that's not what bothers them. So paying to these or paying attention to these principles, again, for example, I don't really open the dura for normal craniotomy in a circumferential fashion. I just do a little X or cross, which is easier to close. It's you know, less problematic, and it's actually also a little bit faster potentially. You know, again, there is this notion that dura has to be closed watertight every time. That has been debunked even in prospective randomized trials. And at least in the supratentorial space, that is not necessary. The posterior fossa or infratentorial space is obviously a different proposition, and you need to pay really close attention to the dura closure there. But in the supratentorial space, it's more about achieving a reasonable approximation without having to spend you know, complete time periods there to close this. Keeping the incision away from the hardware is important as far as I'm concerned. You know, having so like maximum distance between your incision and the scar and the hardware prevents erosion of the hardware through the incision. You know, you can see here in the top example, this is so like a horseshoe type incision. If you know, you look at the weak points of that closure is those corners. So, you know, when they heal, if you combine that with having hardware in that corner, that is potentially a recipe for wound infection and problems. And also you can use the periost to cover the hardware and really have another layer there to you know, close this. And again, you know, these are all things that we should be doing anyway, right? So I'm hopefully not telling you anything that is groundbreaking new here, but to try and make this actually happen in every single case and pay attention to these is important. And same thing goes, we give regional blocks to our patients, and that has allowed us to use less pain medication afterwards and also intraoperatively, and is really been beneficial to the patient because they essentially wake up with their head not hurting. They can't feel their head, period, for a couple hours, and that gets them over this initial hump until non-steroidal anti-inflammatory medications really kick in and help them. And this is really, you know, looking at the whole spectrum or the whole continuum of postoperative care. When complications occur, a lot of complications occur in the first couple hours. So when you get people across that hump, you know, they do much better and have a much better, I guess, likelihood of going through this entire surgery episode without problems. So the idea is here to have a system that allows you with a high reliability to do these surgeries, to go into these and have the patient come out just like they went in without any problems, which is really important when you're talking about the proposition of why you fix unruptured aneurysms, especially smaller unruptured aneurysms, right? Because they're not giving the patient any symptoms. We're doing this purely prophylactically. You know, if you don't leave that patient exactly as they went in, you to a certain degree have done that patient a disservice. So looking at the quality of this or the dimensions quality, obviously there's different ways of striking this. There's different ways people talk about quality. I do think that innovation has a part in this, but really it's about the outcomes and the patient experience, but then also how much of the resources you put into this. And that's where, potentially sometimes, we have to look also at what endovascular brings to the table, which potentially maximizes that patient experience, but not always, the cost. And it certainly also, as it was talked about, is not always the superior method for outcomes. So we look at, our things with a predefined methodology. We have a whole department that looks at our surgeries and determines, how they went. This is not something that I do or my partners, so there's no bias there. These are prospectively defined data points. And these are dashboards that we build around this. How do we do, which elements of these cases were done? And we look at the trends over the month or the week, the year, since the inception of the program. And, what I want to look at here is, we have a baseline population of people that had a craniotomy before we started this program. This is in 2017 to 2018 now. And then we have what we call proven care or proven recovery, I guess, for this craniotomy program. We can do this since the inception or for just 1 year outcomes. And we can show that we have, less complications, less length of stay, less readmissions, and also a zero mortality in the confines of this program. Now we're looking at, some vascular cases. And I started doing this a while back, and then, I have 4 and now 5 partners who are doing these methods as well. So part of the challenge here has been to translate these best practices from just me and disseminate them to my partners. And we can see here, these are lifetime graphs. So, basically, if you have a good outcome, you move a little bit of a step down. If you have a bad outcome, you move a step up. So, you can see here, for example, there's a jump. We had a bad outcome or complication in this patient. So our overall, track record here is, captured in this graph, and you can see that it moves the track record into a bad direction, and then it takes a couple of 10 or 20 perfect cases before you're back to that original point. So we have both for the complication, we can show that the program patients are, doing better. We have less readmissions over time. We do have the ability to bend that cost curve down a little bit. And also we have a pretty robust, I guess, reduction of the length of stay every time. That seems to be the most robust over time here. And that is not predicated on selecting or cherry picking cases. This is a result that is actually true even if you adjust for the case mix index, which is a measure of the complexity of the case. And the result is really achieved through having less variation. It's not that we get everything right every time, but we have less outliers. And that is really, I guess, the key message here, the key takeaway, that a program like this allows you to have less outliers and less variation of care and have more predictable care. We also were able to do this across surgeons. We were looking at our outcomes here. And, we can look at our programs also, how we do as a department, if you will, or as a group of people, because some of these things have long memories, right? So if you mess a couple of patients up, or if you mess a couple of cases up, then it takes you a while before you can really say that as a group, as a department, we're doing a service to the environment, to our patients, because we're back at achieving these good outcomes. And we are proud to say that we're not buying one bad or good outcome for the other. So we are able to send our patients more often to home, and we don't incur more readmissions for that. That is a big concern in the US here, that we send too many patients to, let's say, rehab or nursing facilities instead. Of course, having better control of your costs allows you to reinvest those margins and build bigger programs, bring better technology in. So that's an important aspect of these things. So in conclusion here, small steps add up. Every step counts. Operational excellence starts with every case. You got to get every case right somehow. And in this framework has allowed us to do this for cerebrovascular procedures, but also craniotomies at large. And we have effectively could implement this at a larger system with multiple surgeons involved. So we're not limited to just like a single person experience or something that is not replicable. So with that, I'm looking forward to questions later on. Thank you very much.
We can't hear you, Manas.
Okay. Thank you, Dr. Clemens. It's a difficult topic because all the time we are satisfied with what we do, and difficult to think how we can be better. And to become 1% better, we have to put in 100% effort. And we'll have lots of questions at the end. And now I'll request Dr. Suresh Shankar to please introduce Dr. Sanjay and to invite him for the talk.
Thank you, Manas. It is always a great pleasure to introduce my good friend, Sanjay Behari. Most of us know him so well that you don't have to introduce him, but for the audience, which is from abroad, I think I'll just say a few words to introduce Sanjay Behari. He is a professor and head Department of Neurosurgery at the SG Postgraduate Institute, Lucknow. He has a tremendous achievement in academic areas and has been very active in the academic activities. He has got a large number of peer review journals, articles in the textbooks, and textbook edited himself. He has been the editor of the Indian journal, the Neurology India, during his editorship. The journal's ranking has gone way high up as compared to the previous years. What is more important is his interest and love towards education and teaching the undergraduates, the postgraduates, and the fellows. He has been very active in the national and international conferences, hands-on workshops at his center as well as at the other centers, very active in seminars and now in webinars. So Sanjay, I think it is my great pleasure to introduce you to this audience. Today he's going to talk about his favorite topic, the ICA aneurysm. So welcome, Sanjay, and let's look forward to hear you.
Thank you very much, sir, for this kind introduction. And after this wonderful lecture on the nuances of clipping versus coiling by Professor Mishra and the management of vascular care in the US by Professor Clemens, I'd like to talk on a very, very specific topic, and that is the controversies in the management of paraklenoid segment aneurysms. And I'd like to address 11 controversies with you. The first controversy is, why are there so many different classifications of internal carotid artery? And why is the facial anatomy of this region so important? There are different classifications, but what you have to remember are just some segments of the internal carotid artery. The C4 segment, which is the cavernous segment, the C5 segment, which is the paraklenoid segment, and the C6 segment, which is the supraclinoid segment. The paraklenoid segment extends from the end of the cavernous sinus and the beginning of the clinoidal segment, which is the proximal dural ring, right up to the origin of the posterior communicating artery. So our area of interest is from the proximal dural ring to the distal dural ring to the posterior communicating artery and the origin of the ophthalmic artery. This is the segment of the ICA that we are concerned about. The other very important thing is, why is facial anatomy of this region so important? Well, we will answer this question as we go along, but the important thing here is that the cavernous segment is under a facial layer, and then there is a condensation of this facial layer with the proximal dural ring. And beyond that is the clinoidal segment of the internal carotid artery, or the C5 segment, which is only a potential space that is exposed by the clinoidectomy. And then comes the distal dural ring, and just distal to the distal dural ring is the ophthalmic artery, which goes along with the second nerve. The important thing is that the planum sphenoidale, or the flat part of the anterior cranial fossa, the dura covering that, also continues with the distal dural ring and continues laterally with the carotid oculomotor fascia. The proximal dural ring, on the other hand, goes below the anterior clinoid process, and therefore this is just condensing and joining with the cavernous sinus. So this portion of the cavernous sinus, this portion of the clinoidal segment of the ICA is covered by the fascia, which is known as the carotid collar. And when you remove the distal dural ring as well as the carotid collar, you get some proximal segment of the ICA. As you can well imagine, in order to expose the proximal optic nerve also, you have to drill the planum sphenoidale and also excise the fascia over the planum sphenoidale and also the fascia which is covering the optic nerve. The second controversy is, why are there differences in the nomenclature of paraklenoid aneurysms? In a sense, there are different kinds of paraklenoid aneurysms, and each one of them has a separate clinical significance and requires separate management problems. The most common is a carotid ophthalmic aneurysm, which is at the junction of the ophthalmic artery with the internal carotid artery. A part of this aneurysm will be hidden within the bone of the anterior clinoid here, and this might be elevating and causing optic nerve compromise here. The second aneurysm is a little distal to that, which is a dorsal wall aneurysm. And this is usually a sessile aneurysm. And if it ruptures, this just comes out like a button from the internal carotid artery and becomes extremely difficult to clip. The third is a ventral wall aneurysm, which is situated on the ventral surface of the internal carotid artery, just opposite the origin of the ophthalmic artery. And a part of the aneurysm may be actually in the cavernous sinus. Then the fourth aneurysm is a transitional aneurysm, which starts from the supraclinoid segment to the clinoidal segment to the cavernous segment. And this is the aneurysm where a trapping of the ICA with a bypass is the most appropriate treatment, unless an endovascular treatment is also used. So when we look at some of the examples that we got in our center, you have this classical carotid ophthalmic aneurysm, which is arising. So this is the ophthalmic artery. This is the dorsal aneurysm, which is arising from the junction of the ophthalmic artery with the internal carotid artery. You have this ventral wall aneurysm, which is directly opposite the ophthalmic artery here. And this is a ventral wall aneurysm. The third is a dorsal wall aneurysm just after the exit of the ICA. This is the clinoid. And you see that there is a dorsal button here, and this can be easily ruptured. It is absolutely sessile. And finally, we have this transitional aneurysm from which you have the distal ICA, which is originating from it. And this is the ophthalmic artery also originating from here. And therefore, if the cross flow is good, you can do a trap, or you can do a trap with bypass in this case. The controversy number 3 is, what is the difference between a superior hypophysal artery aneurysm and a carotid cave aneurysm? This is a problem which has vexed a lot of us, and also it has vexed me. So a superior hypophysal artery aneurysm arises a little higher than distally than a carotid cave aneurysm. And it arises from the junction of the superior hypophysal artery with the internal carotid artery. And most of the aneurysm is beyond the distal dural ring. So when it ruptures into the subarachnoid space, and it is pointing towards the sella medially. On the other hand, a carotid cave aneurysm is arising a little more proximally. So a part of the fundus of the aneurysm may be subarachnoid. The entire aneurysm may be within the extradural part of the clinoidal segment. It may arise from the clinoidal segment of the ICA, and it may be completely extradural. So if it ruptures, there may not be any subarachnoid bleed, or if a part of the fundus is in the subarachnoid space, this can also bleed into the subarachnoid space. The interesting thing is that this is a little more proximal as compared to the superior hypophyseal artery aneurysm. And the other very interesting thing to differentiate with the two angiographically is that a superior hypophyseal artery aneurysm will usually have a clear neck, which is distinguishable from the ICA on an AP angiogram. Whereas a carotid cave aneurysm, because there is so much of limited space, so this will be overlapping on an AP angiogram with the wall of the ICA. And this is the way to differentiate both of them. You see that this is a classical superior hypophyseal artery aneurysm, which is pointing toward the sella. This is anterior, this is posterior, this is tuberculum sellae, this is dorsum sellae, this is pointing towards the sella. And when we look at the operative images, this is the second nerve, this is the internal carotid artery. And once the second nerve is mobilized, you see the neck of the aneurysm, you see this asterisk, which is pointing towards the neck of this aneurysm. And this can easily be clipped with double clips, preserving the lumen. Whereas a carotid cave aneurysm, you see that this is the dorsum sellae, and the carotid cave aneurysm is pointing antero-inferiorly and close to the cavernous sinus. So this is antero-inferiorly close to the cavernous sinus here. It is when we went from this side, you went from this side, the left side. This is the second nerve. We tried to reach the anterior-inferior segment, and it was impossible to reach this segment. So we had to just apply muscle and fibrin glue here. And luckily, this aneurysm has not ruptured till now. So you see, this is point more proximally, more downwards, and it is a part of it is in the clinoidal segment there. The controversy number 4. What are the different sites where a proximal control of ICA is taken? So there are several places where an ICA proximal control is taken prior to performing surgery on a carotid ophthalmic aneurysm. First is A, which is the neck. So you can easily take control in the neck. And how do you differentiate an internal carotid artery from an external carotid artery? The external carotid artery will usually have branches, but internal carotid artery does not have any branches in the neck. So that is the best way to differentiate an external and internal carotid artery. Then the second is in the petrous bone, you can actually get a very good control in the Glassock's triangle. And how do you find the Glassock's triangle? You have the greater superficial petrosal nerve. So there is an arcuate eminence on the petrous bone here. So from the arcuate eminence, you draw a line to the foramen spinosum, and this is the greater superficial petrosal nerve. And this is the foramen ovale. You have the mandibular nerve. So lateral to the greater superficial petrosal nerve, or just underneath the greater superficial petrosal nerve, on the lateral aspect of it is the Glassock's triangle, and medial to this is the Kawasai's quadrilateral. So this forms the surface landmark. The greater superficial petrosal nerve forms the surface landmark of the petrous internal carotid artery. The third is in the cavernous sinus itself, you can actually get access to the internal carotid artery and take proximal control. You can drill the clinoid process and get proximal control at the clinoidal segment of the internal carotid artery. And finally, if the aneurysm is a little distal, then you can also get a proximal control at the supraclinoid segment of the internal carotid artery. Then there is a technique of suction decompression, whereas your endovascular colleague will put an endovascular balloon inside, and while you are dissecting the aneurysm, the blood can be sucked out from the aneurysm and the proximal ICA can be blocked. And this is the process of suction decompression. Controversy number 5. Why is clinoidal drilling actually required, and what are its principles? So this is a very, very vexing question which has troubled all the beginners who are doing this procedure. So when we are coming from the greater and lesser wing of the sphenoid in a frontotemporal pterional craniotomy, so we drill a part of this. So this is the anterior clinoid. It has 2 roots. One is the anterior root here. So a part of the root of the anterior clinoid process, you drill when you're coming by the greater and the lesser wing of sphenoid here. The second part of the root you drill the anterior root you drill when you're deroofing the optic nerve here. So then you are communicating these two segments of the roots of the anterior clinoid process. The third part of the anterior clinoid process is the posterior root here, or the strut of the anterior clinoid, which is between the optic foramen and the superior orbital fissure. So when we are drilling this anterior clinoid process, what we are doing is to actually drill the strut and mobilizing the anterior clinoid process so that it can easily be dissected out. The last part becomes mobile and can be easily dissected out from the internal carotid artery. Now, why is clinoidal drilling actually required? So it is interesting that you have this carotid ophthalmic aneurysm. You see the optic nerve here. This is the internal carotid artery. And a part of the aneurysm, the proximal part of the aneurysm, is actually hidden behind the anterior clinoid process and the planum sphenoidale. So the planum sphenoidale has been dissected out. And first part is always to drill the planum sphenoidale to deroof the proximal part of the optic nerve. And this, then the clinoid segment is, the clinoidal bone is, anterior clinoid process is drilled. This is drilling the optic strut and you get the carotid collar. This is the distal dural ring. Here is the proximal dural ring. So the ICA actually curves from the distal dural ring, proximal dural ring, and goes into the cavernous sinus. So this gives you proximal control. It also helps to get a proximal part of the neck of the aneurysm that you can get here. And the most important part, which is not often discussed, is that the optic nerve can be easily mobilized when you have actually drilled the planum sphenoidale. And when you mobilize the optic nerve, you can get to the aneurysm. Now it's seen much more than what it can be seen here, and then it can be clipped. So the pressure on the optic nerve has been completely removed. So drilling the anterior clinoid process has three functions: to get a proximal control of the parent vessel proximal to the aneurysm, to get to the proximal part of the neck of the aneurysm, and the third is to get optic nerve mobilization in order to see an aneurysm which is lying below the optic nerve. Controversy number 6. What are the indications of extra or intradural clinoidectomy? And what are the steps of surgery? I would say that for any paraclinoid segment aneurysm, you can do an extradural clinoidectomy. The only problem is that there are two types of aneurysms where an intradural clinoidectomy is always preferred. And we had both these aneurysms. So one of them is a carotid ophthalmic aneurysm with the proximal part hidden by the anterior clinoid process and pointing dorsally. So if you try to drill the anterior clinoid process from an extradural portion here, there is a possibility of the aneurysm sac rupturing and you're not being able to control it. So here an intradural clinoidectomy is required. The second is this aneurysm, which is a giant aneurysm, where the proximal segment is just proximal to the, just at the clinoidal segment. And therefore, drilling the anterior clinoid process gets us to the proximal segment. Now, what are the steps of the extradural clinoidectomy? So this is the globe. You see that this is the clinoid process. This is the frontal, extradural frontal lobe and the temporal lobe. And this is a small band of dura, which is the dural band. And by cutting this orbitodural band here, by cutting this, it is possible to mobilize the temporal dura from the cavernous sinus dura. And you get this entire triangular piece of bone extradurally, which is the clinoid process. So you see how well the clinoid process is seen. And you can see the 3rd, 4th, and 6th and the V1 divisions of the in the interdural portion of the cavernous sinus here. So you see how well you can see the clinoid process. And by drilling this portion of the clinoid process, you see the internal carotid artery and you get an extradural control over the anterior internal carotid artery here. So during live surgery, you see that the cavernous sinus dura can be separated from the temporal dura here, and you can actually get this completely. And then you see this triangle piece of bone that you can easily drill. And this is the extradural clinoidectomy that you can actually do. But cutting this orbitomeningeal band is a very important part of surgery that you must never neglect. And a zygomatic osteotomy often helps in this surgery. And an intradural clinoidectomy, what are the steps? So this is a frontal and temporal lobe. This is the sylvian fissure. You do a sylvian dissection. You have the second nerve. You have the internal carotid artery here. This is the frontal lobe. Planum sphenoidale here. You see the ICA. You see the beginning of aneurysm and the second nerve here. This is the third nerve going into the cavernous sinus. You can also see the PCOM artery. Expose the planum sphenoidale. This is where the anterior clinoid process is, and this is where the cavernous sinus is. This is the second nerve, internal carotid artery. The planum sphenoidale has been drilled. You see that the second nerve is completely laid bare. On the medial side also it is drilled in order to actually mobilize the second nerve. Then the anterior clinoid process is drilled and the last part is mobilized. And once it is mobilized, you can dissect it from the internal carotid artery using a dissector. And there you see the carotid collar, you see the ICA, this is the distal dural ring, this is the proximal dural ring, this is the cavernous sinus, and this is the carotid collar here. And this is the distal part of the ICA. So now you see how clearly all these things are seen. And now because you have mobilized the optic nerve, you can go proximal to the aneurysm, the superior hypophysal artery aneurysm. This is the proximal part of the neck. This is the distal part of the neck. This is the clip being applied. This is one clip applied and the second clip applied more proximal to it. Then the aneurysm is opened and decompressed from inside. The clot as well as blood is decompressed from inside. And then it is not mobilized because it is a giant aneurysm. And this is the last part of surgery. Controversy number 7, direct clipping of neck versus ICA reconstruction of large to giant aneurysm. So when do you perform a direct clipping of neck of an aneurysm? And when do you perform reconstruction using multiple clips of large to giant aneurysm? So you see, this is another superior hypophysal artery aneurysm that we had. You see, this is the aneurysm and this is the ICA. This is the second nerve. You see, this is the aneurysm, which is downwards. Again, the same step, planum sphenoidale exposed, the clinoid process exposed, drilling, mobilizing the second nerve, and then you see the aneurysm going down and you can clearly see the neck of the aneurysm. You can clearly see the neck of the aneurysm going medially towards the sella. So once you can see that, you can see this, so you can apply a clip here and then you can actually get the entire neck of the aneurysm, and this is the ICA. And then a little bit of fibrin glue and muscle has been applied onto a little bit of aneurysm which was left here. Whereas you see another superior hypophysal artery aneurysm. You see this is medially directed superior hypophysal artery aneurysm. This is another superior hypophysal artery aneurysm directed medially. And this is the ICA. This is medially directed superior hypophysal artery aneurysm. But as you go down, the same steps of surgery, you see ICA, but you see the carotid collar being exposed here. This is the falciform ligament over the second nerve, and a part of the fundus of the aneurysm is medial and a part is lateral. So you see that this aneurysm is medial to the ICA and part of the aneurysm is lateral to the ICA. So here applying a clip here is not feasible at all. So you see that this is a part of the fundus of the aneurysm which is pointing towards the sella and a part of the aneurysm which is pointing towards the cavernous sinus. So first a right angle fenestrated clip which took the ICA into its fenestration is applied to preserve the lumen of the ICA and actually take control over the fundus of the aneurysm. But here you have to be very careful that the blades of this aneurysm are on the fundus and not close to the neck, because this may slide a little and actually occlude the lumen of the vessel. So try to keep it on the fundus and if required, remove clots from inside the giant aneurysm. And then 2 fenestrated straight clips were applied in order to actually take care of the residual fundus. So here, when the aneurysm was on both sides of the ICA and there is a wide neck to it, then it is much better to reconstruct the lumen of the ICA rather than to apply a direct clipping. Controversy number 8. What is the management of a sessile dorsal wall aneurysm? So this was one of our patients. You see that this is the ICA and you see this aneurysm. It is almost like a pseudo aneurysm. There was an acute subarachnoid hemorrhage. This was pressing on the ICA and a part of the neck of this aneurysm was actually seen. So we thought we will go in and apply a clip. We had dissected it very nicely, but as soon as we applied this clip, so a part of this aneurysm avulsed and there was significant bleeding And I have the video, but there's no time to show this video, but you can see that there was bleeding. So what we did was we took clips which took the fundus of the aneurysm and reconstructed the vessel a little, and you can see the lumen here, and a part of the neck can be reconstructed. What are the ways of dealing with this sessile dorsal wall aneurysm, which does not have a neck, and which is almost like a pseudo aneurysm, which may not even have an adventitia or a muscularis layer there? So what you need to do is that there may be just a clot surrounding it. So one of them is that if there is a neck present here, you can actually clip the aneurysm, but sometimes you can wrap the neck of the aneurysm and apply a clip on it, or you can wrap the entire vessel and apply a clip on it. Or you can take fenestrated clips, which are either straight or right angle, and a part of this fenestration is actually closing a part of the lumen of the ICA, so that the entire neck of the aneurysm is clipped. So this is a very useful way, and the clip does not slip out. And another way is to do a parent vessel occlusion with bypass. And this bypass could be a low flow STA, MCA bypass, or a high flow bypass. But then we can come to the indications for a bypass. So the controversy number 9 is, when do you perform a balloon test occlusion and a bypass? We had this giant aneurysm here, and you see that normally you should get this good flow here. You get this good cross flow, and also see the cross flow from the PCOM, from the vertebral artery to the anterior circulation. But here there was hardly any flow. We had done a bypass, and there was this giant aneurysm. So proximal clip was applied, and we tried to reconstruct using fenestrated clip. And whenever you're applying fenestrated clip, so what happens is that the blade will usually rupture the aneurysm. So the blade ruptured the aneurysm, and then we could apply 4 clips in tandem, 4 fenestrated clips in tandem. And we thought we had done a great job. We had also done a bypass. But post-operatively, you see that there was this huge hemispheric infarct which was present in this patient. And one important thing that we notice is that one is that the cross flow is not good. And another thing is, if the lenticulostriate perforators, if the proximal part of the IC is compromised, then there is no way you can prevent this infarct from occurring. So if there is a distal obstruction, distal to the lenticulostriate branches, then there is a possibility of salvaging. Proximal, that is very difficult. Dr. Shekhar has given a very nice algorithm. A low risk patient is one who's tolerated balloon test occlusion, and on cerebral blood flow, there is greater than 35 ml per 100 gram of blood flow per minute. A patient with moderate risk also tolerates 20 minutes of balloon test occlusion, and cerebral blood flow shows 15 to 35 ml per 100 gram per minute. A severe risk patient is one who's tolerated balloon test occlusion, but whose cerebral blood flow is less than 15 ml per 100 gram per minute. And D is a patient who does not tolerate balloon test occlusion and develops neurological deficits during the procedures. Categories B, C, and D require a bypass procedure. So a patient who has tolerated balloon test occlusion, who has a good cross flow, and whose cerebral blood flow is greater than 35 to 50 ml per 100 gram per minute is the only person who is a low risk group wherein a parent vessel occlusion may actually give reasonable results. Controversy number 10. Concurrent bilateral kissing paraklenoid segment aneurysms. Do we simultaneously keep it using a single approach, or you use 2 different approaches? So we were lucky to recently get this patient who had this kissing aneurysm. You had this giant and large aneurysm on one side and a small aneurysm, and you can see that these are all both clinoidal segment corrective ophthalmic aneurysms, and you can see that there are kissing aneurysms here. So we decided to go from this side, which is the there. So this beautiful diagrams have been made by our postdoctoral fellow, Dr. Priyadarshi Dikshit, and it shows the anterior clinoid process, the ICA. So one aneurysm, the ipsilateral aneurysm, this is frontal lobe, this is temporal lobe, was actually elevating the second nerve, and you could see the opposite aneurysm. So first we did the exposure of the planum sphenoidal, the clinoid. We exposed the carotid collar, the proximal ICA, and then we applied fenestrated clips, reconstructing the ICA here, just proximal to the anterior choroidal and the PCOM artery. The other aneurysm was on the other side. Then we actually opened the planum sphenoidale of the opposite side, drilled the planum sphenoidale, and mobilized the optic nerve, and then applied a direct clip from the same side to the opposite side. So the contralateral approach to a medially directed superior hypophyseal artery aneurysm is only possible if the contralateral aneurysm is unruptured and is either medially directed or superiorly directed. The planum sphenoidale may have to be drilled if the aneurysmal neck is partially hidden or if the chiasma is prefixed. So if the aneurysm neck is partially hidden, that side planum sphenoidale may also have to be drilled. And a giant contralateral aneurysm should not be operated using this approach. So you see the operative steps. There's the frontal lobe, there's the temporal lobe, there's the sylvian fissure, there's the second nerve. So this is the ICA and a beginning of the aneurysm here. So you see this is the second nerve completely, there's the frontal lobe. You see this is the pecom artery, this is the ipsilateral aneurysm, this is the ipsilateral aneurysm, this is the contralateral aneurysm, and the blue arrow is pointing towards the junction of the ipsilateral and the contralateral aneurysmal fundi. And this is the planum sphenoidale. So first, the IC is reconstructed by 3 clips, which are passing below the second nerve and clipping adequately the ipsilateral aneurysm. The contralateral aneurysm is actually also elevating the second nerve, and this is the ICA that is seen. The planum sphenoidale is drilled on the contralateral side. So this is the contralateral ICA, which is of a different color, and this is the aneurysm. The proximal neck of the aneurysm is not seen. And then we applied 2 clips on the contralateral aneurysm. So from an ipsilateral side, keeping the optic nerve in the center, this is the anterior cerebral artery, there's the contralateral second nerve, this is the contralateral ICA, this is the ipsilateral ICA within the fenestrations of the 3 clips, this is the MCA. So it was possible to clip it because the other aneurysm was not ruptured and it was pointing medially. The final controversy is, in superior hypophyseal artery paraklenoid aneurysm, why is parent vessel preservation not practiced? And I was very curious to know about this. And then I went and read literature, and we have mentioned this in our publication, which was published in Neurology India. And the interesting thing is that the superior hypophyseal artery is a very important artery. It supplies the pituitary stalk, it supplies a part of the anterior pituitary, and it also supplies the optic chiasm. But it forms a plexus of vessels. So if you are clipping the aneurysm only ipsilaterally, and 1 or 2 small branches of the superior hypophyseal artery come in your clip, it does not make any difference because there's a plexus of vessels. But if you are clipping both sides, then you have to meticulously preserve the superior hypophyseal artery. Thank you very much for your kind attention. I'm grateful for this privilege. Thank you so much.
Thank you, Dr. Sanjay, for the excellent lecture and pointing out the 11 controversies, which Professor Mitra had presented large aneurysms, and you actually made it to controversy, and he has presented as techniques. We'll have, I'm sure we'll have a lot of discussion during the question and answer session. I'll request, now it's my turn to introduce Dr. Parithos. Dr. Parithos, has done his post-graduation at All India Institute of Medical Science, and then he worked as a faculty as additional professor of neurosurgery at National Institute of Mental Health Neuroscience, Bangalore. He is a dual vascular neurosurgeon. He has done a 1 year of fellowship on vascular neurosurgery at Wayne State University, Detroit, and then he did an endovascular fellowship at endovascular at Detroit and a microsurgery fellowship at Stanford. And he does both endovascular as well as microsurgery. So we'll have an unbiased opinion on treatment of ruptured aneurysm with endovascular means. Parithos, please set your screen.
Thank you, Dr. Manas, for both this introduction and also this opportunity. I'll just share my screen. Right. So As Dr. Manas told, I do both procedures, and there are a bunch of them, a bunch of us who have now started doing a lot of endovascular procedures, especially because of the advent of stroke in the whole system, and that has absolutely changed the game. So you will see more and more of them. And that gives us a unique perspective of handling data on both sides. I do believe that ISAT and other endovascular trials have absolutely completely changed the game, and not just because of the occlusion rates or other one-year outcomes or other things, but just the patient's preference is so much towards an endovascular treatment that it is something that is very, very difficult to resist. That being said, microsurgery is not going anywhere, and I will try to show it in some of these slides here. So we will just see how stenting happens in the acute cases. As you know, the stent-assisted coiling in clinical setting was described in 1997, and they were quickly adopted as promising adjuncts with potential mechanical, hemodynamic, and biological properties. And it provides mechanical support to, one, prevent coil prolapse in wide-necked aneurysms, and also for flow diversion, and can provide a scaffold for endothelial growth and vessel healing. It was almost always used for ruptured aneurysms in the beginning, even though there were no trials comparing stent-assisted coiling with other techniques, and it was used as a humanitarian use device. But it was really extensively used, and there was a strong criticism of in AJNR, and you must read this article, but as to how this has become completely mainstream without any major evidence. But then, as it happens with technology, once you start using a technology, it is adopted in other situations as well. And then it started to be used in ruptured aneurysm with little evidence for the use of that. What one must remember is that in ISAT, the difference between the poor outcome of endovascular treatment and surgery was 6.9%. And this was significant, and it remained significant for a long time in mortality, even though it was not significant in the good outcome, but mortality difference remained the same. But we must remember that any increase in complication in endovascular treatment would basically take away the advantage of endovascular treatment over surgery. And any addition of morbidity and mortality in endovascular treatment with use of more devices or different devices is unwarranted, especially in ruptured aneurysm, and also in unruptured aneurysm, where, as Dr. Clement said, it's just a thing sitting inside the head and not causing you any problem. So initial experience with the stent-assisted coiling was not very good. It was in 2005, where adverse event was seen in 25% of patients, and permanent deficits was there in 9.3% patients. This is from Michelle Mawaz's group in Houston. And the ruptured aneurysm also was published very soon after in 2008, where procedure-related complications were in 21%, thrombobolic complications in 11%, and 30-day mortality was 20%. So these are not insignificant numbers, and this would probably be inferior to what we would get with surgery, especially in very experienced hands. So these are the issues with stenting in acute setting: dual antiplatelets, thrombobolic complications, hemorrhagic complications, EVD, VP shunt, and other technical issues, and we will see all these things. Advantages, of course, are we are able to treat wide-necked aneurysms, especially in posterior circulation. It prevents coil prolapse by providing a scaffold. There are higher immediate occlusion rates in many series. As happens with much of the use of stent, there is progressive occlusion and lower recurrence and retreatment. So we will just go through some case series, comparison of stent-assisted coiling with simple coiling. Unfortunately, there is no comparison of stent-assisted coiling and surgery. Then stent-assisted and balloon-assisted coiling, which are the two different techniques for the coiling of wide-necked aneurysms. And then we'll go through some meta-analysis. So these are the stenting techniques which you would hear, which a surgeon would not be able. So there is something called jailing of microcatheter, where you put the microcatheter inside the aneurysm before you deploy a stent, and then you deploy a stent and then coil through the jailed microcatheter. Then there is something called coil through, which you first deploy a stent and then take the microcatheter, coiling microcatheter through the struts of the stents, which can be done. It cannot be done through the flow diverters. It can be done through the other other stents. Then in the third one, you coil, and then later you put a stent. And in the next one, you coil with a balloon, and then you go ahead and take out the put a stent. There is another one which is done in emergency situation, which is called bailout stenting, where if there is a coil prolapse from the aneurysm, which was just being done through balloon assistance or a normal coiling, then you go ahead and put a stent just as a bailout technique. And these are emergency and not planned procedures. So this was one of the first ones, large data coming from Dr. Morey's group. And you would see here that most of these aneurysms were unruptured. And you would see that the morbidity and mortality was 12%. And the 7.4% complication, procedure-related death was in 4.6% of the patients. And this led to an editorial by another very, very experienced group by Dr. Von Ruiz. And he says basically that this is an alarmingly high rate of serious complication, especially in patients harboring mostly unruptured aneurysms. And we hope that they adapt the endovascular policy in such a way that serious complications are decreased dramatically. So our talk is mostly on ruptured aneurysms. So this is one of the, as I said, this is one of the first ones to be published. And this, we have discussed this with high mortality and high procedure-related morbidity. Then came one from the Dr. Pascal Jabor's group, where they had 65 patients and 2/3 of them were in anterior circulation. The good outcome was only in 63.1%. There was high mortality with 16.9%, and there was 7.7% hemorrhagic complications and 7.7% thromboembolic complications. Another series with 11.8% thromboembolic and 10.8% hemorrhagic complications. There were specific aneurysms which were studied as well, with ACOM aneurysm, where with coil alone, the rupture was much less, the thrombus was much less, and it was dramatically more in ruptured and thrombus cases. They tried to see how to do it. The antiplatelet medication free stent coil, and this was also procedural thromboembolism was quite high, and poor outcome was also high there. The Chinese group presented their experience with enterprise stent-assisted coiling in 59 patients, and this was done ultra early, and they had fairly good outcomes, much better than the previously reported results, with procedure-related complications only of 8.5%, which is very, very acceptable, and almost 90% of them had good outcomes. But as is mentioned, the first series which was done was also fairly early, less than 72 hours, and this had different results. If we compare stent-assisted coil embolization of the intracranial aneurysms in acutely ruptured and unruptured aneurysms, we will see that the complications are almost 10 times higher in ruptured aneurysms as in unruptured aneurysms. So these are two totally different characters. The permanent complication rate was 11%. 5 out of 45 had early rebleed, and 4 of them died. And this was also shown in this large series of stent-assisted coiling by Chalouhi et al. For 508 patients, where only 9% were ruptured, but favorable outcomes were there in 99% of the elective unruptured aneurysm patients, but only 51% of them in ruptured patients. And this is basically a summary of all the series that we have. And we see that thromboembolic complications and hemorrhagic complications are not insignificant. And these are significantly higher than the simple coiling that we have, which is to be expected because the stent-assisted coiling is done only in the very complicated aneurysms, and we will come to that. But overall, the results are not as encouraging as coiling, simple coiling, or even balloon-assisted coiling. The first meta-analysis was done in 2011, where they had 339 patients, and we see that the clinically evidenced strokes are 4.4%. There is total hemorrhagic complications of 8%, and in-stent thrombosis of almost 0.3%. And favorable outcome was seen in 81%, 13% of the stroke itself. This is the latest one, which is published in 2020, where thromboembolic and hemorrhagic complications were seen in 9.1% and 8.7% of the patients, and total complication rate was 20.8%, with 57% of aneurysms were completely occluded, and favorable outcome was done in 75%. So these are fairly high numbers of thromboembolic and hemorrhagic complications in this. And they also reported the EVD, which we will come to later, and there was EVD related hemorrhage of 13.4%, and angiographic outcomes at follow-up was 74.7% complete occlusion here. And these are the thromboembolic complications which we can go through. There is high post-operative ischemic event of almost 20%, and post-operative re-rupture was also there in 26.4%. So we see that thromboembolic complications are there in 9.1%, and hemorrhagic complications are there in 8.7%, which leads to total complication rate almost 1/5 of the patient. When we come to simple coiling versus stent coiling with meta-analysis, we see that there is perioperative complication much higher, 20% versus 13% only in coiling. However, the mortality and the favorable outcomes are similar, and this was seen in this meta-analysis. When we compare the stent-assisted and balloon-assisted coiling, there was one series only, but there is no meta-analysis, and we see that there is similar ischemic events, but the aneurysm perforation was more than balloon-assisted coiling, but mortality was higher in stent-assisted coiling itself, thus leading us to believe that if at all we need to treat some wide-necked aneurysms, and we can know which one to treat with stent-assisted coiling and which one to treat with balloon-assisted coiling, depending on the width of the neck and the dome neck ratio. And the lower dome neck ratio, the lower neck size are usually treated with balloon-assisted coiling, and the higher ones are stent-assisted coiling. Then we go through the risk of ventriculostomy, which is the stent-assisted coiling requires dual antiplatelets, sometimes ticagrelor and prasugrel as well. And everybody has documented high risk of EVD-related hemorrhage. And this was seen in this series from Emory, where there was, in 3 of the 7 patients had intraventricular hemorrhage and a lot of complications. This is another article from Pennsylvania, where in group 1, where there was only coiling, the symptomatic hemorrhage was only in 0.9% of patients, whereas in stent-assisted coiling, it was almost 15% of the patient. And similar result was there in another series where EVD-related hemorrhage was there in almost 1/4 of the patients, while only 5% in simple coiling itself. There are strategies to prevent it now. There is one strategy is to do the EVD before loading the patients on antiplatelets, or there is another strategy which is stopping the clopidogrel and aspirin, giving continuous tirofiban, doing the EVD, and then again starting this whole thing. What is the alternatives to stent? Obviously surgery, but we'll discuss that later. There are 2 other alternatives to stents these days, which is web device and flow diverters. We'll go towards web device because it's a very exciting development, especially in unruptured aneurysms. These are intrasacular flow diversion devices. These are self-expandable embolization implants, single layer of braided nitinol platinum wire. And detachment is electrothermal, and it is attached to the flexible delivery wire. So this is how it does. There is no metal inside the parent vessel, and this is the main attraction of this. This is used in wide neck bifurcation aneurysms, and there are various sizing issues, but this is how basically it is done. You take the web device inside the aneurysm, deploy it, and you're done. Since there is no metal, there is no need for dual antiplatelets. Most of the patients are either on no antiplatelet or single antiplatelet, and hence it is suitable for wide neck bifurcation aneurysms. And it may be more acceptable in ruptured wide neck bifurcation aneurysms, and we will see that. The WEB-IT trial, which was published last year, there was only 1 complication, but only 9 of them were ruptured. And the occlusion rates are not great. I mean, the total occlusion rates are at 12 months, 53.8 and 84.6 had acceptable occlusion, which is only a small neck. 14% are still filling, but it is better than the bifurcation aneurysms treated just with coiling and stuff. So this is a work in progress. But the first group of people who published a series of web in ruptured aneurysms were from Van Ruijt et al. and they said total thromboembolic complications of 9% with 17% mortality, mostly in poor grade. And we see that there is 23% neck remnant and 4% incompletely occluded. But this is a recent series published in World Neurosurgery from 2008. And this showed that web complications were fairly high. There was 27% web-related complications, 5 device protrusions, 2 SAC operations, and 2 thromboembolic complications with web-related mortality of 12% and permanent deficit 3%. So as I said, this is still a work in progress. We are learning more about it, and especially in patients with ruptured aneurysm, this is something to be used fairly cautiously. This is the web meta-analysis, which shows that in ruptured aneurysms, the perioperative morbidity is 2%, the perioperative mortality is 15%, and thromboembolic complications are 21%. Great for unruptured aneurysms, but it is still not very, very good for ruptured aneurysms. How about flow diverters, which is the talk of the town in acute rupture? So we use it for blister aneurysms, for fusiform aneurysms, dissecting aneurysms, and very rarely for sacular aneurysms in acute rupture cases. So there is a meta-analysis in acute rupture, which was published in 2018. And this there was 15 retrospective patients, two retrospective multicenter and 3 prospective. And they were mostly blisters. 1/3 of them were dissecting fusiform, and less than 1/5 of them were sacular aneurysms. Here, the immediate occlusion rate is not great, but the delayed occlusion rates are very, very high. It is almost 90%, and it is very good in dissecting and blister aneurysms, but poorer in sacular aneurysms. So for blister aneurysms, flow diverters really works very, very good. And I did a literature survey sometime back. Only bypass and high flow bypass and occlusion has a better outcome than flow diverters. But as all of us know, that doing a very high flow bypass in acutely ruptured sick patient is not a very easy thing as well, and requires extreme expertise. And hence, the trend is going more and more towards use of flow diverters in blister aneurysms these days, but with slightly poorer results than bypass and occlusion. The worst results are actually in direct clipping, as Dr. Sanjay has shown. The vessels are very, very fragile, and if you see the literature, the worst results come from direct clipping of these blister aneurysms if you take a large number of them. Overall complication rate was 17%, but higher complication rate in sacular aneurysms, hence again saying that we should keep these flow diverters for dissecting and blister aneurysms and not for these sacular aneurysms as well. Of course, there was higher complication rate in posterior circulation because there were a lot of perforators there. And even in unruptured aneurysms, we use these flow diverters with a lot of caution in posterior circulation. So before giving the examples, I would just like to say that stent-assisted coiling has a very good role in ruptured aneurysm as well, but only when the complications are, the alternatives are lesser. So suppose we get this kind of an aneurysm, which is a dissecting large aneurysm in the basilar trunk. There is really no other alternative. Direct surgery is not an alternative. Balloon-assisted coiling is not an alternative. So we went ahead and packed this. We used a braided stent and did a loose coiling. And this patient was in coma when he came to us. And at follow-up, he is clinically normal, and the basilar artery is fairly, very, very, very nicely remodeled here. And he remains well at 5 years follow-up here. So this is something that you have to use a stent-assisted coiling in these. Again, in this kind of a ruptured patient where there is a basilar trunk, wide neck aneurysm, you can't, it is very difficult to clip. You can't really go ahead and do balloon-assisted coiling here because the dome is very, very small and the neck is very, very large. So we used a Leo stent again, and we coiled it here, and it remained stable. Similar to this patient where we stent coil it here. But the controversy comes in this kind of a ACOM aneurysm, which is ruptured, which is wide neck, which is large, and there is really no point in doing a stent-assisted coiling in these kind of patients. And these patients are much better served with simple surgery, or if you can do it, a balloon-assisted coiling. Similarly, this one, where there is a large neck and there is a fetal TCOM coming from here. So we went ahead and clipped it, even though there was a lot of people who would try and do a stent-assisted coiling in these kind of ruptured aneurysms here. But when it comes to wide neck basilar top aneurysm, we go ahead and do a stent-assisted coiling. A multilobulated ACOM, which is completely ACOM, is going there. There is a trend towards using flow diverters in these kind of patients, but really these patients are much better served by using a simple technique of clipping of these aneurysms. Suppose you have this MC aneurysm, which is branches coming off. You can use, and this is ruptured, you can really use a couple of stents or balloons and stuff and go ahead and coil it, but really patients are better served in this. So for conclusion, for wide neck ruptured aneurysms, stent-assisted coiling is definitely feasible. There is high technical success, but there is definitely higher complication rate than coiling, which is probably equivalent or lower than worse than surgery itself. And both their thromboembolic and hemorrhagic complications are there. There is definitely high complication on dual antiplatelets in EVD. Web results in ruptured aneurysms are not that good to make it mainstream. And for flow diverters, better to reserve it for blister and dissecting aneurysms. And stent-assisted ruptured aneurysms only when there is no other alternative. Complex posterior circulation aneurysms, very, very complicated anterior circulation aneurysms, poor grade and FD for blisters and dissecting. Because of higher thromboembolic and hemorrhagic complications stenting in acute setting, other aneurysms to be treated with alternate techniques like balloon-assisted coiling and or surgery. Thank you very much for your kind attention.
Thank you, Dr. Parithos. As I understand, if it's a simple aneurysm, maybe coiling is better, but if it's a complex aneurysm, surgery will be preferred if one has the experience of treating the complex aneurysm, because treating complex aneurysms with endovascularly, not many people have the experience. So I think the complication rates are higher at the present state. With this, we'll start off with the panel discussion. I'd like to request Dr. Lokendra Singh to give his opinion, as well as if he has some questions to ask, I can ask questions to any one of the speakers.
First of all, I think I must congratulate all the speakers because the topics were extremely good. And particularly, I was really interested what Dr. Clemens was talking about. The whole issue between clipping and coiling, I think for how long it will really keep on taking place, this discussion, but definitely, as we understand from the Dr. Pandey's presentation, because he has experience of both the worlds, and what Professor Basant Mishra, he has a very good experience about treating complex aneurysms with the microsurgery. I think surgeons are still going to remain in business. I don't think surgeons are very soon going to fade away from the field of aneurysm surgery. And because the flow diverters are comparatively new, so more and more studies are needed, and then we will come to know the complications associated with those. So probably it's too early to say that it is the panacea or it is the ultimate thing. So I think definitely, because the problem with those studies have been that they are all not properly done studies actually. Quite a lot of bias is there. And these are not properly done randomized studies, you know. And whatever they say, the international studies, for example, I said, the 77% patients from UK alone, they call it international study, but it's a single country study basically. So, I mean, there are inbuilt flaws in the studies also. I'm not saying that endovascular treatment is not good, it is good. But I think the dust is yet to settle down. And I think gradually, in due course of time, probably both the things will get their own space and place. And surgeons need to study, probably they have to improve their surgical results, and they have to bring down the complication rate. So probably we need to further improve our microsurgical techniques. Stay in the hospital. I was quite interested in Dr. Clemens' article that how can you reduce really the complication rate, reduce the stay, reduce the, the surgical trauma which you inflict. I mean, I can call it surgical trauma because you operate and cut the body after all. So these things can further really bring us back into business in comparison to the endovascular treatment. I think this is what is my input. Thank you.
Thank you, Dr. Lapender. I request Dr. Babu to give his comments and if he has any questions to any of the speakers. Dr. Babu, please unmute yourself. Yeah.
You can see all my post-it notes down here. I've been taking notes the whole time. So I agree. I think early on we realized that endovascular treatments were going to raise the bar for surgery, and I think that's a more healthy way to look at our treatments. I mean, Clemens, Peritos, and myself, we're all we understand the endovascular side of things, but we also appreciate surgery. I think one place, when I was there in Chennai about 2 years ago, one of the things I really walked out with was hoping that the Indian neurosurgeons would look over at the U.S. and realize how important it is to still maintain the surgery, but also embrace the endovascular side of things. And I think that's happening there. I'm happy to see that. But things like smell, vision, pain really go into that team approach to neurosurgery that Clemens talked about. The flow diverters still, I think, as Dr. Mishra mentioned, I mean, we still really have an understanding about good vision outcomes. The Surpass stent, which was the more recent flow diverting stent, was the first one to really have independent ophthalmological examinations. And so I'm looking forward to those good evaluations of how patients were really doing pre and post with those large aneurysms. All of us have had the large giant aneurysm that we decided to flow divert that went ahead and lost the rest of their vision because now we can't go and decompress them because they're on dual antiplatelets. We have to think about that. But headache and multidisciplinary management, all of my patients start with muscle relaxants the day before surgery. All of my patients start with, we do some regional blockade as well, but involving the anesthesiologist early, I think, is important. So I think really a couple of questions that I might throw out there, and maybe with Dr. Bahari, it's when we talk about your comments on hypophysal were interesting, because I mean, frankly, nowadays from an endovascular standpoint, the narrow-necked hypophysal aneurysm is the poster child for endovascular therapy, right? You see that whether or not it should really be treated, we can debate that later, but from a rupture standpoint, but we will coil bilateral superior hypophysal aneurysms all the time, right? Why do we think that we're worried about the hypophysis surgically if we coil them all the time? And maybe comment on that.
I mean, obviously, we have a very active endovascular group, both in neurosurgery as well as in radiology, and we are coiling aneurysms all the time. But if there is an aneurysm which is actually causing compression of the optic nerve there, and so we did not go with the plan of actually taking the other aneurysms unless the conditions were absolutely propitious for us to actually go and clip the other side. And what happened was that when we actually were successful, maintained the lumen and clipped the same side, suddenly I realized that the other aneurysm is also pointing directly at me. And with a little bit of plenum sphenoidal drilling, I can actually clip that one also. So then I went ahead and did that. The interesting thing is that, I mean, if financially and in terms of completeness of surgery and in terms of decompressing the optic nerve, it's also a useful maneuver to keep practicing the art of clipping the aneurysms, especially the carotid ophthalmic aneurysms.
Yeah, I think all of us have been there where we look across and we say, oh, we can get control. And it actually is, frankly, sometimes it's easier from the other side. But then we have to think about our surgical bar. How is the patient's smell? How is the patient's vision when the clip is lying next to the nerve? We have to think about those things. You mentioned that economics. One of the interesting things, Clemens and I were texting back and forth a little bit. When a surgeon over here wants to clip an aneurysm, they say they'll talk about how the patient wanted it, or the patient did, or the patient. I've heard frequently from speakers there that the reason to clip it is economics, right? The patient couldn't afford it. And I wonder sometimes, is that still the case now? Is there still an economic reason for surgery to happen in India versus here, where are probably not
that's one of the considerations. The second consideration is follow-up. It's very difficult for patients in India to actually keep coming and getting evaluated for residual neck, this and this a little bit of fundus remaining, for the compaction, for some stent failing. So then it's much simpler to just go in and do a complete job, and you'll be surprised at how many people still prefer to get their aneurysms clipped as compared to getting it coiled.
Yeah, I think.
May I just answer? The economics is a very, very important factor in India, because unlike in many of the Western countries, most or majority of the patients in India still have to pay from their pocket, major part of their treatment. So today in my practice, I would do more patients, the easy aneurysm. Let me put it, common garden sacular aneurysms, more clipped because of economic reasons than otherwise.
Mm-hmm.
So it's a fact.
Yeah. Actually, that's true, because in my city, for example, Basant in Nagpur, for $150 to $200, that's it. That's the cost for clipping the aneurysm. I think
we have that consideration of follow-up as well. Sorry, go ahead.
No, it's okay. 2,000. I mean, $1,500 to $2,000 is the total cost probably we charge for clipping, including everything, including the clips and medicines and surgical treatment and everything. This is how the economics works in India, because there are pockets of very poor patients, tribal areas who cannot afford, they don't have insurance. Insurance is a big issue here. Not many people have insurance in this country.
Right.
I think the follow-up part is a consideration here too, that if you have a patient that is requiring dual antiplatelet therapy, for example, for a long time, that at least in my practice, I have patients who don't want that, right? Or if I question that, I say, look, we're probably better off clipping this, because I don't actually, to be frank, I don't trust you to be compliant for the next year or two, because if something happens, you're going to have a major stroke because your flow diverter clots off, for example.
I would also suggest, if we really objectively analyze the results of, the endovascular procedures, I do understand that it's very aggressive. But then I've also realized that more and more patients are coming back for a re-procedure. Often they will come back and then you reevaluate and then you do something more toward them. It's not like, it's like it's a one-time job where you say that it's perfect. So for a simple anterior circulation aneurysm, it's a very good option to actually still keep our surgical option open.
Yeah. Dr. Suresh, your opinion on that?
What's that?
But I think that argument goes both ways, right? How many of us truly keep a record of their surgical outcomes as well, right? We sit down with the patient and say, look, in Professor Misra's series, this would be an X%, problem or, good outcome. In Professor Spetzler's series, it's that many percent. And that somehow magically translates to me, right? That's not necessarily fair to the patient, my group, how that does over time, rather than, the best possible numbers I can pick.
Right. Yeah. To me, it's interesting. The follow-up is also is pertinent here when we talk about city versus the private and insurance role. That's a big deal. And the medications. I'll forecast one thing that I also find interesting. Our surgical expertise. We're at a point right now in the U.S. and Clemens, you can weigh in on this, where I think centralization of surgical sites is probably more realistic if we were really honest. Because there are a lot of endovascular neurosurgeons who aren't very surgical anymore, and maybe that that'll happen now. I've been a proponent of that for a while, but then also there's your follow-up again, right? If you start centralizing people within states and then needing follow-up, but Frank, what we're looking at here in Texas is now a lot of the follow-up is virtual. If there's any benefit of COVID. We've really opened up our virtual ability to follow patients and interact with patients and across larger swaths. So I'm hoping, frankly, that the surgeons there and the trainees here start to interact a little bit, because I think you guys are probably seeing more surgical aneurysms than we are.
Thank you, Dr. Babu. I'd like Dr. Suresh to give his comments, and then we'll answer a few questions.
Right. First of all, I would like to congratulate all the speakers for the excellent talks that we heard today from them. First of all, Dr. Mishra's really, it was a masterly talk, I would say. And what we learned from his talk is, how he handles the situations with his own experience. And we also learned that one should know the feasibility of or complex problem, how we do in those circumstances. And it was a very wonderful lecture from him today. I have a question for you, Dr. Mishra. I don't know whether I missed some part of your talk, but then how do you choose or select the type of bypass that you consider in various types of giant aneurysms? How do you decide?
Yeah, we do mostly for, previously we used to do a balloon occlusion test for all cases. But over a period of time, if the patient is young or the patient has bilateral aneurysms, then they don't go through a balloon occlusion test. Now, if the patient is an elderly patient, we do still do a balloon occlusion test. And if the patient passes a balloon occlusion test, either we just do a simple trapping or ligation of the carotid. We don't do a bypass, because all said and done, bypass is a major procedure. High flow bypass is a very major procedure. Or sometimes we do a low flow bypass even when the patient passes the balloon occlusion test, and good balloon occlusion test pass, very good cross, no delay. We would, in a young patient, we would probably do a low flow bypass rather than a high flow bypass. But if there is balloon occlusion test doesn't pass, patient has a bilateral aneurysm, for a young patient, we would go more in favor of a high flow bypass. Again, if the patient is a patient with a subarachnoid hemorrhage, he goes for a bypass more often than otherwise, because the patients who have hemorrhage and who already has ischemic problem or risk of having ischemic problem, they don't tolerate a parent artery occlusion as well as a patient who is not a ruptured aneurysm. Yeah. So more of high flow bypass for patients who are proximal aneurysms. And if the patient has a balloon occlusion test is not very good, collaterals are not very good, or there is a delay, even if they pass the balloon occlusion test, but there is a delay, we would go for a high flow bypass. If the patient passes the balloon occlusion test, young patient, we would go for a low flow bypass. Elderly patient passes balloon occlusion test, we would not do a bypass.
I would like I'd like to add one more thing. Whenever you're doing a parent vessel occlusion, you're never very sure. Like, even if you have a reasonable cross flow, it also depends on how fast the flow is and how many peripheral branches are getting filled up with the opposite side vessel. So sometimes you get a good cross flow, and yet when you do a parent vessel occlusion with a low flow bypass, you may have ischemic complication. So in that situation,
actually, Sanjay, we never think about the arterial feeders. We see the delay in the later phases, so capillary and the venous phase. If there is a delay, we have a paradigm now. So we do first a normal occlusion, then a hypotensive challenge, and then if he passes, again, if an elderly patient, we would probably accept it rather than in a young patient, because all said and done, in an elderly patient, the high flow bypass is a major procedure. So we would err towards a less aggressive procedure than for a very high.
One small technique to actually cause an ischemic complication during a bypass is to actually not choose the main vessel, but to choose a little peripheral vessel. So rather than choosing M1 or M2 branches, choosing an M3 branch for a bypass really helps, and fish mouthing it more really helps, because then you can actually, if there is an ischemia, a distal ischemia, it's a small sectorial infarct rather than a hemispheric infarct.
Absolutely. M1, we never choose M1. We never choose M1. Always, all my radial artery bypass or saphenous bypass high flow is always been to high flow bypass is always to M2 in all of cases.
Good, thank you. So Sanjay, just one question for you, if there is time. Most of the aneurysm which you showed of the paraklenoid region, whether they are dorsally facing or ventrally directed, some of them can be treated very well with the endovascular treatment also. So when you are talking, and discussing, counseling the patient's family, how do you really explain all these things so that they accept the this kind of surgery?
No, there are two aspects to it. The finality of a procedure is also very important for a lot of patients. It's extremely difficult for them to reach a center which is actually addressing these problems. So the finality of the procedure is a very, very important consideration. It's more important than you can ever imagine. And if you say that, you can go in for an endovascular procedure, we are also doing that. We can all and this will be the cost. On the other hand, you can also do surgery. It's a routine surgery. It's not something which is not done very frequently. We do it very commonly, and we have reasonable results in patients who are grade 3 and beyond. So grade C and below. So what I'm saying is that a lot of for anterior circulation aneurysms particularly, draining CSF, doing a good duroplasty, removing the clot, instilling in papaverine, they really help sometimes. And and post-operatively, you do find doing lamina terminalis opening. They sometimes really help in kind of addressing the problem with a poor grade aneurysm. So I would suggest that we need to keep this option always open.
Good. Thank you. Thank you very much. Yeah, Manas?
Before I conclude, just there are two important, there's so many questions, but two important questions. One to Professor Mishra. Professor Goyal has asked, how has your practice changed with the advent of all the endovascular treatment for all the paraklenoid aneurysms?
Yeah, actually, I answered to him, but I can read it up. Significantly changed. Number of bypass for especially the cavernous aneurysms has gone down significantly. We don't do it. If the patient, they have access to the endovascular treatment, they go for it. But for supraclinoid aneurysms with mass effect, I personally, I don't think it's a good idea for endovascular treatment. I said, the complications are underreported. I think microsurgery is still a better option, especially if they have a visual compromise and mass effect. So we still advise that. Of course, between what we advise and what finally happens is a different issue. But I believe, and I think there is enough evidence to suggest, if the patient has a compromise of the visual pathway and you do some kind of endovascular treatment, while you can get away many a times, you can burn your fingers, and that's irreversible damage which cannot be corrected.
Yeah, thank you, Dr. Mishra. One last question to Dr. Parithos about because you're dual trained, what percentage of your patients you treat endovascularly and what percentage microsurgery? But before you answer, I will request all the speakers to please answer the questions in chat box because we don't have time to take the answers. Before you leave, please answer in the chat box. Dr. Parithos, please.
I think half of it, we do half of it, or almost 2/3 of the aneurysms endovascularly. And a lot of the decision is for the patients, which is for economic reasons and this and that. So all things remain, and I'll tell this because 20 years down the line, we should actually not have this kind of debate because both of them are surgical techniques. And if we were early adopters of the surgical technique of coiling, endovascular coiling, we would not have this debate. As in, it is only because there are two different specialties involved. That is why we are probably having this debate. So all things remaining similar, most patients would probably opt for endovascular treatment. I would probably opt for endovascular treatment. Probably you would opt for endovascular treatment for these aneurysms. So there is no reason why any other patients will not opt for this. And I think we should be adopters of technology. Otherwise, there will be others will adopt the technology and not refer it to us, as is happening in all the centers of India that all of us know about. And we need to keep the patients with us and not with other specialties, because we do understand the complications and the other specialties as very well. That being said, I'm not against anybody doing it here. What I'm saying is that we should also adopt this technology so as to not have much and to make much better decision, because somebody who knows only endovascular would push all the boundaries to do it the endovascular way, and that is probably not proper. But all things remaining similar, most of the aneurysms, which is probably 70% of the aneurysms, are very well treated. And even if the results are similar, most patients would probably not bother to get their head open, right? So that is why, and the answer is around half to 2/3, and most of the decisions are economic. And yeah, that is the problem.
I would like to differ here, Paritosh. I mean, I completely agree with you that a person should learn both the techniques. However, there's one small thing you must remember, that the spectrum of patients that come to a private hospital are quite different from the spectrum of patients who come to a general public hospital, and their expectations are different, and their accessibility to medical care is also different. And in that situation, for them to keep coming for follow-up and for assessing whether an endovascular procedure is actually being successful or not is extremely difficult. And that, a lot of people don't realize this. So that we keep both the options open there.
I don't disagree, sir. I mean, but I'm just trying to say that we are not a unique country. The aneurysms are the same. The techniques are the same. We are not doing anything different here. So the data which is there in the West is the data where all things remaining. But I mean, I completely agree that open surgery is not going anywhere else. But we also need to adopt the technology so that the specialty doesn't have a problem, because many patients will go to the public hospital and marquee surgeons like Dr. Mishra and people. But as you go one generation down, more and more patients will come to the endovascular specialist rather than the other. I'm not talking about Dr. Mishra or Dr. Loken Singh or you, because you guys are established names. But once you go one generation below, many more interventions are happening, rather than in the similar way, many more stentings are happening as endarterectomy. And this is because we have given our specialty to other specialties, because we have not been adopters of this technique as we should have been. And this is my humble opinion.
Manas, can I ask Dr. Clements one question for Dr. Clements? Can I ask him?
Okay.
Yeah, you have this very nice analysis of your cases, and you spontaneously kind of, with every patient you have these graphical representations of how they respond and how they perform on the follow-up visit and all that. But in most of the cases, the recovery actually doesn't depend on the procedure, whether surgical or endovascular. It actually depends on the condition of the patient ultimately. And so if you have a very poor grade patient and your spectrum is such that you're getting more and more poor grade patients, then your graph will keep on going downwards. Whereas if you're getting patients in Huntington has grade 1 and 2, then you're the procedural part will have 1% morbidity or 5% morbidity or something like that. So I mean, actually, do you really think that your meticulous recording of data really has an effect on the patient management and outcome?
So thanks for that question. I think it's a great one. I think there is this established effect that just looking for, I guess, prospectively recording and writing down what happens is leading to better outcomes, because people, it's like try and do better. But I think you're exactly right on track, right? I mean, we talk a lot about the aneurysm as the problem, right? The aneurysm is part of the larger patient, and you're precisely right that a lot of the bad outcomes or the good outcomes have not much to do with the surgery or the intervention for the aneurysm. It has to do with the larger patient, I guess. And that's where I think, parts of our program, which are geared towards optimizing that patient beforehand, if you have that time, to take that patient, give them the nutritional supplements, for example, give them the expectation and the education of what will actually happen, and really go through that and sit down with that patient, for an hour and talk about this. That seems to have an effect on the outliers, I guess, right? And that's where we see a relative change. If you look at our absolute numbers, we're not, that far off from like everyone else, right? I mean, our absolute, readmission rate is still maybe 10%, things like that, I guess, right? But we can show that relative difference. And that's where it comes back to what I was saying, that, trying to do this right every single time, every case, every step of the way, that aggregates. It's a little bit like your bank account, right? Compounding effects of little steps every time, will lead to a great result.
So basically what you're saying is that the fact that you are doing a very detailed analysis helps to improve results. That's what you were...
That's one part, right? But we already stepped beyond that and said, like, we're going to try and, do this program as a standard for every one of our patients. So it's not just me saying, for example, I'm going to sit down a little bit more with my patients and I can show better outcomes, because then you don't know, is that because I happen to be lucky, I happen to be a better surgeon, I'm better at picking my patients. That's where you take that out, right? Because these are all the patients that come to us, right? We can't pick and choose and say, like, half of you, we don't like that, we're going to send you to the other hospital across the street, because especially where we are, we don't have a hospital across the street, right? So, our next large hospital is like, 3 hours or 2 hours away, basically, that, they could go to. So that's where, having like a systematic approach at this is helpful. And yes, you're right. Measuring is one part, because you also need to know where you're coming from, right? In order to know where you're going, you need to know where you are right now and really, establish that direction. So I agree. And this is very important.
Thank you.
Thank you, Dr. Clemens. And then I'd like to conclude with comment of Professor Mathuria, which has written that both endovascular and microsurgery are complementary, and keeping aside the economy, still 1/3 will need surgery, 30 to 40%, which even Dr. Paritos agrees, and sometimes it becomes 50%. I'd like to, with these few comments, I'd like to thank all faculty and panelists for spending the night in discussing and teaching so many people from all over the world. And we meet again next month, second Wednesday on 7th of October. Thank you all, and good night. I'd like to especially acknowledge the support of INTAS, and especially Mr. Jagrup Singh, who has looked after the logistics, and we hope they'll continue to support the same way. Thank you and good night.
Thank you.
Thank you very much. Thanks.
Good night. Bye.
Thanks for having us.